Welcome to this Cardiological Society of India PG DMDNB teaching program. And I welcome all the dignitaries present here and all the viewers DMDNB who are going to be benefited with this program a lot and has joined this program to this feast. This program, I think it will be most sought of program in Cardiology Society of India history. And this time I thank the President and Executive Committee and Dr. Shantanu Guha that they are planning to do this program every 15 days. To start with, may I request our beloved President, Dr. P.P. Mohanan, to inaugurate this program. Sir, please.
Thank you, Rakesh. The Cardiological Society of India Sub-Council Chair, Dr. Shantanu Guha, who is in hem of affairs of the postgraduate studies, past President Dr. Das, incoming President Banerjee, our AJ editor Rakesh, and previous presidents Satyavanji and many other erudite faculty, and my dear younger brothers and sisters. Today also incidentally happened to be the Valentine's Day, and it is the day that which all of we love our heart. And possibly Shantanu was very insistent on starting this teaching program and the year-long program on this wonderful day where we are the privileged one to take care of this wonderful organ. The cardiac care in India has come of age from the past. Right now, we have the highly skilled cardiologists and, of course, cardiac surgeons who can be compared with the best in any part of the world. All of you know that ours is a rapidly evolving and advancing field, and it needs regular upgradation. Conventionally, the Cardiological Society of India have its 2-day teaching program for postgraduates in every one of its annual meetings. And of course, our sub-council also has been active in having once or twice programs for you. But now we are taking another big step in having a fortnightly teaching program. And we thought that is the need of the hour, which will impart the erudite faculty of the Cardiological Society will impart clinical skills. Of course, the discussion about the various disease process, but also will give you knowledge about the disease prevention skills, the interpersonal communication skills. Now, there could be very many teaching program, training programs. You are at a liberty to attend every one of them. But essentially, I think they should be involved in teaching professionalism. I will also request you to give us a regular feedbacks. Now you can write to this headquarters or any one of the individuals giving your suggestions. If you have any particular area of concern, and that's also very, very important. Another matter which the CSI will be offering to help you is most of you definitely are going to be initiated into cardiovascular research. You are compelled to do at least a couple of dissertations during your 3-year program. The Cardiological Society again is here to help you, support you in your research activities. So I consider it a great privilege, and I'm pleased to inaugurate this year-long teaching program from Cardiological Society of India. Thank you. Rajesh, you are muted. Rajesh.
Thank you, sir, for your kind word and encouragement. And as usual, you always motivate everybody. And I think this is a great opportunity. I call our past president, Dr. M.K. Das, and our president-elect, Dr. P.S. Banerjee, and our chairman of this meeting, Dr. Shantanu Guha, to kindly join as a chairperson and speak few words regarding this program. Dr. M.K. Das, sir, please.
Yeah. Good morning, everyone. Dear President, Dr. Mohanan, Committee Chairman, Dr. Partho Banerjee, Chairman of CSI Postgraduate Teaching Committee, Dr. Shantanu Guha, Dr. Rakesh Yadav, National Faculty, students and friends. Warm greetings from the Cardiological Society of India In fact, knowledge is power, and knowledge and information create a huge powerhouse for any subject matter, especially the advanced subject like cardiology. Over the last few years, Cardiological Society of India has taken many initiatives to build such powerhouse. This teaching program is one of the such programs which was supposed to be held last year, but due to the unprecedented natural calamity or natural or artificial whatsoever is the reason, it actually stalled this. However, CSI cannot look back and restarted the PG training initiative under the guidance of a formidable national faculty who will enlighten all the learners of cardiology, which is advancing leaps and bounds. I'm very much pleased to be in this inaugural session. I'm sure this will be an exciting program, an opportunity to learn and refurbish our information powerhouse, especially the basics of cardiology. The virtual program will eventually become in-person program in due course of time, sooner than later. And let us be part of this beautiful journey and wish you all the best. Pranam, long live CSI.
Thank you, Dr. Das, for your encouraging word. And may I request Dr. P.S. Banerjee to speak few words. Sir, you are muted.
So, good morning, everybody, all the dignitaries and the postgraduate students present in this meeting. It is a great endeavor on the part of the CSI. So, I must congratulate the sub-council, including Dr. Guha, to take the initiative to start this program once again. And I believe that in the era of interventional cardiology, clinical cardiology is almost becoming a forgotten entity. So, I hope that this program will help to promote more and more clinical cardiology, bedside cardiology, so that we can again gain knowledge in the diagnosis of cardiological disease before we proceed for any other intervention. And another important part of the fact that CSI has taken the initiative to start this program, and I am so happy that this program has been conducted by CSI rather than by conducted any private organization. And I hope more and more postgraduate students will join and be helpful for them. And there is no dearth of teachers in CSI all over the country. So I believe the Rakesh is a very competent person to take the initiative and to conduct this program across the country throughout the year. And more students will be interested as the time proceeds. So I wish all the success of this program. And thank you once again for asking me to chair in this CME program. Thank you. Long live CSI.
Thank you, Dr. Banerjee, sir. And may I request Dr. Shantanu Guha, who is the man behind organizing this program and all the thoughts, to speak few words. Unmute, sir, unmute.
Unmute.
Mr. President, sir, all the presidents and past presidents on the dais, all the erudite cardiologists present here, all the students and friends. This is perhaps a new journey for the CSI to regularly take this type of classes. I would rather say classes, because the main purpose of this program is not only to impart knowledge, but also to prepare the candidates, DMD candidates, for their examination. So looking at the program, you can have an insight that we will be presenting cases which are given in the exams, like multivalvular heart disease case as it is today. In the next day, we will be presenting a congenital cyanotic heart disease, then a congenital acyanotic heart disease, exactly the type of cases which we discuss in the examination. And the subjects given along with the cases are again of extreme importance. Like today, we will be discussing on the newer advances in the management of rheumatic fever and rheumatic heart disease. Next day, we will be discussing an approach to a patient with congenital cyanotic heart disease. We'll be discussing the X-rays, ECGs, imaging, different imaging parameters, and all these things in course of time. For some of the DNB students and for some DM students, we have kept one session on OSCEs as well, because these are becoming more and more important in the passing days. Last year, the entire DNB examination, I can say our 80% of the examination was held on OSCE. So this is becoming a very, very important thing. So let us have some insight into it. Let us have some knowledge about it. So I will be circulating this program to all the members of CSI and to all these students who are participating here. In the process of organizing this program, we did some mistakes as well. We should have sent the invitation to all the CSI members, which we did not. My apologies for that, and we will be rectifying it from the next session onwards. With these few words, I think it is time we go to the real program. The first case will be a patient of multivalvular heart disease, which will be presented from KGMU Lucknow by Dr. Swati Sharma. This duration of this session will be 1 hour 15 minutes. The examiners for this will be Dr. Shatyavan Sharma, Dr. K.C. Goswami, Dr. Balachandar, and Dr. Rishi Shetty. And the subsequent followed by a talk on newer advances in the management of rheumatic fever and rheumatic heart disease. This will be taken up by Dr. I.B. Vijayalakshmi. So without wasting any time, it is exactly 2 minutes to 11. Let us move to the session proper, and I hand over to Dr. Rakesh Jadhav. Rakesh, please organize the session for the case presentation.
Thank you, sir. And I think we should start. Dr. Swati is there. Dr. Swati, what you have to do it, you have to present the history, as you are presenting in your final examination, and the history in detail, and then the salient negative finding. And after history, you have to discuss the differential diagnosis, then go to the clinical examination. And clinical examination as you are being given in your examination. And then what investigation you want, you can ask from the examiner, you can show. And then the final differential diagnosis. So present the case as you are presenting in your examination.
Exactly. Rakesh, I interrupt just for one. I take 1 minute. Swati, you presented as it is being presented. You have seen several examinations. You present it as it is presented in the examination, and you may be interrupted at any point of time by your examiners. Dr. Yes, Goswami, I am not finding him. Did you see? Dr. Goswami, are you here?
Maybe Shantanu or Rakesh can come in place of Goswami.
In that case, I will.
Sir.
Rakesh.
Sir, I will be there, sir, in between.
You join as an examiner. I am coordinating the things. Okay. Swati, please present.
Good morning, sir. Good morning, respected teachers and all the participants. I'm going to share my presentation. I'm going to present a case of a 26-year-old female resident of Hardoi, Uttar Pradesh, housemaker who presented to us with chief complaint of breathlessness since 9 years, fatigue since 6 years, and palpitation since 3 years. History seemed to be reliable given by patient herself. My patient was apparently asymptomatic 9 years back when she developed dyspnea of insidious in onset and progress.
Dr. Sharma, sorry to bother. Can you just put it on the slideshow mode, please?
Yes, sir. Yes, sir. Sure. Thank you, sir.
Thank you, ma'am.
My patient was apparently asymptomatic 9 years back when she developed dyspnea, which was insidious in onset and progressive in nature. For the initial 2 years, she had dyspnea only with slight limitation of physical activity with NYHA class 2, which gradually progressed over next 6 years to the extent that she was having dyspnea on routine household work, NYHA class 3. And in last 1 year, her dyspnea has progressed to the extent that she is having dyspnea at rest, NYHA class 4, which on taking some medications from local facility improved to NYHA class 3. Patient also complained of paroxysmal nocturnal dyspnea and orthopnea since last 1 year, which improved after taking oral treatment at a local facility. My patient was having fatigue since last 6 years, which was insidious in onset, gradually progressive in nature. Over last 6 years, initially during heavy exertion only, progressing to getting tired on usual physical activities, and over last 1 year, she is having fatigue on rest also. There was history of palpitations since last 3 years, which are gradual in onset, regular in nature and pounding, increase on exertion, and relieved on taking rest. There were several episodes of palpitations which were sudden onset and irregular in nature, occurring even at rest, associated with increased dyspnea, for which she had visited emergency and relieved with injectables.
Swati,
Yes, sir.
can I ask you one or two questions before we
Yes,
proceed
sir.
further? Now,
Yes, sir.
you gave a history. It's a young patient who started having symptoms for last 9 years.
9 years.
Uh, a year back, she started complaining of PND, and she also started having fatigue and palpitations. If you have to translate these symptoms into some hemodynamic terms, what do you think is happening to this patient?
Sir, seeing this long history of 9 years, this is going in favor of some valvular stenotic lesion.
No, actually,
Hemodynamic.
I asked you, I didn't ask you what etiology you are suspecting. I
Yes,
asked
sir.
you that suppose you have to translate into hemodynamic terms, what does this history indicate to you? What is happening? A patient having dyspnea, then is starting to have PND, also simultaneously is having fatigue, and now is having palpitations.
The lesion is getting hemodynamically significant, and she is entering into heart failure, sir.
Okay. Do you think this history suggests you that this patient has got left heart failure or right heart failure?
Left heart failure, sir.
Left heart failure. How do you explain fatigue with left heart failure?
The fixed cardiac output. Fatigue is a symptom of exercising muscles. So, if there is fixed cardiac output, if patient increases his or her activity, then the blood is shunted towards vital organs and
So,
less to
so,
exercising
so you
muscles.
want to tell me that this patient is having fixed cardiac output for last 6 years?
Not for 6 years, not for last 6 years, because such a
And
long
no,
history
no,
is
no.
not
Please,
possible.
please don't get. You are presenting very nicely. You are presenting extremely nicely. So just try to analyze these symptoms. Like you told that this is indicating a left heart failure, which I completely agree, endorse that history of PND and orthopnea looks like a left heart failure. But your fixed output with fatigue going on for last 6 years.
Maybe, sir, during the initial period, she might be having some anemia, which is leading to her fatigue, and then her lesion progressed to hemodynamically significant and cardiac output decrease, sir,
Anyway,
because she is having fatigue and palpitations.
I won't persist on that, but fatigue is for last 6 years.
Shati,
Yes,
can
sir.
I ask one question to you?
Yes, sir.
So from the history you told about the palpitation, fatigue, and dyspnea, which progress to the PND, orthopnea, etc. So what do you think? This is a case of a volume overload situation or pressure overload situation?
Sir, I think Dr. Goswami has joined. So may I request Dr. Goswami sir to please switch on his video.
Can you get?
Sir, yes, sir. Yes, sir. Stenotic, sir. Pressure overload condition, and after like palpitations since last 3 years, which were regular and pounding, suggestive of regurgitation also.
So it is a mixed valvular disease, you want to say?
Yes, sir.
So which is the predominant one from the history?
From the history, predominant is stenotic.
So is there any history of DG spell or blackout during the course of the illness?
No, sir. No, sir.
So
Okay.
can you account for all the symptoms because of the predominant stenotic lesion?
Maybe, sir, during the initial period, she might be having some.
What is the cause of palpitation? What is the cause of palpitation in your case?
The 3 years history of palpitations are suggestive of regurgitation, sir. Volume load and
Is
LV
more
is
common in
contracting
stenotic?
with more force.
No, you are tell your history. The character of palpitation is these palpitation which you have presented are volume overloaded or it is something else. In your slide,
It's a
just read it. In your slide, you just read.
Yes, sir. History
Because-
of palpitations since last 3 years, which are gradual onset, regular in nature, and pounding, and increase on exhaustion, relieved on taking rest. These palpitations suggest us to regurgitation, sir.
Yes. And this
And then
palpitation, several episodes of
last-
palpitation.
Yes, sir. Since last 1 year, she had several episodes of sudden onset at rest palpitations, which were even at rest, and they were associated with increased dyspnea. And she had to visit emergency for that. These palpitations, as per patient, were irregular. So these suggest arrhythmic palpitations, new onset AF.
Okay, that is fine. But predominantly your patient presented with dyspnea and palpitation without any definite history of P syncope or syncope. So it
Yes,
doesn't
sir.
go in favor of a stenotic lesion. Okay. So do you like to revise your diagnosis clinically from the
Yes.
history alone?
So, but
Which
palpitation,
one? Which should be the predominant lesion? Is it regurgitant or a stenotic lesion?
sir, both could be predominating because palpitations were since last 3 years, and dyspnea has more longer history of 9 years and progressive. Then later on, she started having fatigue also.
Okay, Dr. Swati, let us try
Yes,
to
sir.
answer Dr. Satyavan's question, which is still remained unanswered, at the hemodynamics of the symptoms, the hemodynamics of PND, hemodynamics of orthopnea, and dyspnea. What does it tell you in terms of its pressures?
Venous hypertension.
Yes, sir. This thing, PND, presence of PND and orthopsia shows us that she's having raised pulmonary capillary wedge pressure and increased LA pressure
Okay.
of around 24-25 millimeter of mercury, sir.
Okay. Supposing the patient does not have mitral stenosis, can she still have PND
Yes, sir.
due to?
Severe mitral regurgitation, sir.
All right. So mitral regurgitation will increase LA pressure, or it can produce PND without that.
It
Can
increase
just
LA
LV dysfunction produce PND? Can PND
LV
occur as a
dysfunction,
result of LV
leading-
dysfunction?
LV dysfunction leading to increased LV diastolic pressure, which can also result in increased LA pressure, sir.
So that is due to what actually? The hemodynamics is correct, but actually what is happening? There is a increase of LV diastolic pressure, increase of LA pressure. So what happens?
Increase in LA pressure transmitted to pulmonary veins and
Yeah.
increase in
So-
PCWP.
So you should say that it's an expression of diastolic dysfunction. So that is what we have learned in recent years, that PND can also be a result of diastolic
LV
dysfunction.
diastolic failure. Yes.
Orthopnea? Orthopnea is diastolic dysfunction or systolic dysfunction?
Orthopnea is, sir, can be present in any heart failure, more towards systolic heart failure, sir.
So it can be present, although it can, diastolic and systolic can go together, but it is systolic because of what? Because the fluid movement is mandatory. Is fluid movement mandatory in PND? I'm just going about the hemodynamics because Dr. Satyavan asked this question.
In orthopnea, there is increased venous return.
Yes.
But in PND, it is not mandatory.
It's not mandatory. So what is mandatory there in PND? What is in PND is as if the heart is exercising in sleep. The heart is actually, the patient is exercising in sleep.
There is, yes, sir, there is decreased sympathetic drive. There is presumed that there is decreased LV contractility during sleep.
Okay. Okay. So coming back to this question of stenotic and regurgitative deletion, fatigue is a symptom of what?
Fatigue is a symptom of exercising muscle getting less blood.
Between stenotic and regurgitant lesions, can fatigue occur in?
Yes, more in regurgitant lesions.
Not in stenotic? Or both?
It can occur in stenotic lesion, yes, it can.
Okay. So if you have palpitations, same hemodynamics, palpitations due to aortic regurgitation, palpitations due to mitral regurgitation, what is the symptom which will distinguish between the two types of palpitations?
Fatigue, sir.
Fatigue, isn't it? Because the LV out goes into the LA and forward output is not compromised in AR, correct? Okay.
Yes, sir. Fine. In AR, fatigue will not be predominating. In MR, it will be there.
Okay, right.
Yes, sir.
So go ahead, or other examiners, please.
Yes, thank you, sir. I'm coming to negative history of my patient. There is no history suggestive of rheumatic fever in the past. There is no history of cough and hemoptysis. There is no history of chest pain, syncope. There is no history of any neurological deficit, abdominal pain, or discoloration of digits. There is no history of abdominal distension, swelling of lower limbs. There is no history of prolonged fever.
What history did you ask from the point of view of rheumatic fever?
Sir, I asked about...
Please tell salient points.
Yes, sir. I asked about sore throat, followed by a few weeks, like 4 to 6 weeks of, after that, 4 to 6 weeks of joint pain, swelling, or rashes, not rashes mainly, joint pain, swelling, and dyspnea, dyspnea, palpitations, and after a longer period, was she having any abnormal limb movement?
Abnormal limb movement for what?
Poria, sir.
Right. Okay.
Yes.
Swati, won't you ask for any migratory nature of the involvement?
Yes, sir. Yes, sir. Joint pain and swelling, were they involving small joint or large joint, and were they migratory or non-migratory?
Yeah.
Yes.
Are arthralgia an important component of rheumatic fever in our country? Or
yes, sir. Of course, in high-risk areas where prevalence is more, arthralgia, especially polyarthralgia and monoarthritis, being taken as major criteria in the revised criteria, and this monoarthralgia is a minor criteria. Whereas in low-risk settings, polyarthritis is major and rest other are minor.
Can we get some clues in the history whether this is a streptococcal sore throat or it's a viral sore throat? Because sore throat is a very common symptom, it can be due to...
Most common are viral, mostly 80% are viral.
Can there be some clues in the
CentOS criteria, so we can apply it to like absence of cough. One is absence of cough, one is this cervical lymphadenopathy. Am I audible, sir?
Yeah. Go. Please go
Yes.
ahead.
Yes, sir. Absence of cough, cervical lymphadenopathy, hoarseness.
Of features suggesting a pharyngitis. Streptococcal
Yes, sir.
pharyngitis is more common in rheumatic fever, right?
Yes,
Tonsillitis,
sir.
pharyngitis. Okay.
So in modern times like this, what is the closest differential diagnosis of the streptococcal or a pharyngitis in a child aged less than 8 years? I've given the clue.
Tonsillitis, sir.
No, the differential diagnosis of this condition, of this pharyngitis, in a child less than 8 years of age. And unless you are aware of this condition, you will not pick up because the treatment is very rapid and it's a mimic of rheumatic fever. You know, there are some mimics of rheumatic fever, isn't it? What
Yes,
are the
sir.
mimics? Like post-streptococcal rheumatic arthritis, PSRA. But what is this
Recover.
condition, which now people are increasingly recognizing in children less than 8 years of age, and you have to be on the alert to pick it up? What is that? You said lymphadenopathy, you said sore
Yes, sir.
throat. If I tell
Yes,
you
sir.
one more thing, you will tell the answer. Say conjunctival suffusion, palmoplantar, scaling. What is this condition?
Scarlet fever, sir.
Not scarlet. Scarlet fever is not in India so much.
Scarlet fever is old.
Old. Anything else new which tells you that immediately you have to start treatment so that the long-term effects are prevented?
Sir, Kawasaki.
Kawasaki's disease. It's very close. It's very close. Remember that you may not get the total criteria. And age less than 8 years is, of course, it's a mandatory criteria. So you'll have to look at that. Right. So the stress in rheumatic fever is always recurrence. You say recurrent history of, fleeting joint pain. So the stress is largely on recurrence, although you may not get that history of recurrence quite often. Okay.
Yes, sir.
Swati, you asked that there is no history of hoarseness of voice. What is the importance of hoarseness of voice in your history, or what?
Sir, LA enlargement can lead to hoarseness of voice, as in Ortner syndrome, sir. Left recurrent laryngeal nerve compression.
What
And
else?
hoarseness of voice can also be due to compression of this bronchus, sir.
Did you take any history from the point of view of Vashi on rheumatic prophylaxis?
Yes, sir. I took history. There was no history suggestive of regular intramuscular injections, monthly or 3 weekly. She did not give history of that, but I'll be saying it later on. She was since 1 year or in the last pregnancy when she was hospitalized. She got some hint of some heart disease, and in last 1 year when she was extremely symptomatic, she got to know that she's having heart disease of valvular, so she was getting treatment, but she was not getting injectables. She was getting oral penicillin.
Okay.
If I may come in, Dr. Swati.
Yes, sir.
So the way we talk in department when we present cases, when you have taken your complete history, and before you have gone on to your negative history, you must have a set of differential diagnoses in your mind based upon which you take your negative history, because negative history is the only part of the history that you can take provocatively from the patient. So were you thinking after your history only in terms of multivalvular or rheumatic heart disease, or were there other things in your mind? Of course, you will come to your differential diagnosis, but I want you to answer each point of your negative history on what was running in your mind when you asked for other things, and are there other things that you missed probably that would have broadened your horizon from rheumatic heart disease to, let's say, other etiologies? So did you miss on anything from that point of view?
Sir, I'll start from my negative history. I took history of chest pain, syncope, to know about aortic valve involvement, and hypertrophic cardiomyopathy, and neurological deficit, abdominal pain, discoloration. I took history to rule out any history of cardioembolic phenomena, abdominal distension and swelling of lower limb. I took history to rule out right-sided failure or cardiomyopathy involving right heart, leading to abdominal distension and swelling, and prolonged fever to rule out infective. Any episode of prolonged fever will help me to rule out infective endocarditis and tuberculosis.
Any history of pregnancy in this lady and childbirth, and
Yes,
what
sir.
was the first child age, and any deterioration in symptoms that you can relate to that?
Yes, sir. There is a history of pregnancy in the past history, sir.
Okay,
Actually,
we'll come to that.
if
We'll
I
come to that.
understood Dr. Rishi properly, then I think what he was trying to bring out from you was that are you considering any other etiology which can give rise to this type of disease? And that's why he again gave you a hint of, from the point of view of any pregnancy. So you were
Yes, sir.
looking only from the point of view of the rheumatic valvular disease, or whether your differential also includes a cardiac muscle disease or a pericardial
Cardiomyopathy,
disease. Yeah.
peripartum cardiomyopathy.
Yeah. Does that make any uh, is that important in this case? Is that relevant in this case? So that's what I think he was hinting. That's how I understood him.
Yes.
Rishi, am I understood you correctly?
Yes, perfectly, sir. I wanted to broaden the horizon
Yes, absolutely.
of the discussion to various other etiologies of, congenital and muscular and
Pericardial, muscular, and
yeah,
valvular.
and neoplastic also. Yeah,
Okay.
tumors of the heart also.
Yes, sir. So, coming to past history, there is no history of surgery or intervention in past. There is no history of suggestive of asthma or no past history of tuberculosis. Coming to personal history, she's married 10 years back at an age of 16. She has one kid. There is no history of any abortion. Her first pregnancy was at age of 17 years, which was uneventful and delivered at home. During her second pregnancy, which was at age of 21 years, she had dyspnea at less than usual activities, NYHA class C, and development of pedal edema, which improved after delivery to NYHA class 2. Her last delivery was institutional at some primary health center with normal vaginal delivery. As per patient, the vaginal delivery course was longer than the first one, and baby died soon after birth. And why she was shifted to institution from home? Because she was having class 4 dyspnea at that time.
Yeah, so she's 26 years old and she had her first pregnancy at 17,
At
exactly
17.
9 years before, and that is the time since when your history starts, 9 years. So clearly, the first pregnancy did precipitate whatever pathophysiology was going inside her from a little earlier age, or brought out a new pathology. From that angle, you have to think.
Yes.
So this is what I keep telling, that even for the students, that when you present in the examination, it doesn't matter that you'll have to go back to past history. Now here is a case when symptoms have started with pregnancy. So there's no harm in saying that the symptoms of dyspnea, all that started when she was 17 years of age with the first pregnancy, which was uneventful, but the second pregnancy at 21 years of age. So this will give the examiners a clear picture that she was asymptomatic before that and something had worsened during the pregnancy. So there's no harm in relating it to personal history, which sometimes the examiners may not wait till personal history. So it's better to give your and this is more important for patients who has had an intervention. If the patient has had an intervention, then you must start before the intervention, during the intervention or after the intervention, and then follow that. It doesn't matter at all when you are mixing up a little bit of personal and past history.
Yes.
Dr. Swati, in pregnancy, when she started the symptom? During first trimester, second or third trimester? Is it
So in
important?
the second trimester, yes, sir. It's second trimester, she's saying around.
What are the conditions which worsen during pregnancy? Cardiac condition? Or
Sir,
valvular?
valvular, mainly stenotic lesions, then cardiomyopathies, low EF, sir, and
What about
then
mitral regurgitation?
so regurgitation lesions are generally well tolerated, sir,
Because
because there is a fall in systemic vascular resistance. During pregnancy, sir. And there is pregnancy, there is a volume overload situation, which is not tolerated with stenotic lesions, sir, because PCWP rises, sir.
Swati, does this history fit with the diagnosis of peripartal cardiomyopathy? This personal history and what you told us in last half an hour, 20 minutes, and what we were discussing. Does this go as a peripartal cardiomyopathy or peripartum heart disease or whatever you want to call?
Sir, her first pregnancy, she was not much symptomatic, sir. It was uneventful and delivery was okay, and child is also fine, sir. But in second pregnancy, she was having dyspnea, and before second pregnancy and after the first pregnancy, she was having dyspnea during that period. Uh,
What is the usual natural history of peripartal cardiomyopathy? Usual. Of course, in medicine, there can be always a wide spectrum. Usual natural history.
It comes in primary gravida or multigravida? Peripartum
so
cardiomyopathy.
primary.
No. It comes
So,
in multigravida. Peripartum cardiomyopathy is a disease of multigravida, not primary gravida. So that way it will fit in. I'm just saying.
yes, sir. So can I continue, sir?
Please.
Yes, sir. So, treatment history, she is taking regular oral treatment since last 1 year from a physician in her town where she was diagnosed as having some heart disease, and history of injectables given to her during emergency visit, which is happening since last 1 year. She is the third child of non-consanguineous marriage, and her two other siblings, which are older to her, apparently healthy and doing well. There is no history of any congenital heart disease in family. She belongs to low socioeconomic status. To summarize, patient is 26-year-old female presented with complaints of dyspnea since 9 years and fatigue since 6 years and irregular exertional palpitation since 3 years, which were insidious in onset, gradually progressive from NYHA class 2 to class 4, associated with paroxysmal nocturnal dyspnea and orthopnea since last 1 year, with episodes of sudden onset irregular palpitations since last 1 year.
So what provisional thoughts come to your mind? 1, 2, 3, or only one? You think this is a valvular heart disease?
Yes, sir.
You think it's
My
valvular?
first, yes, sir. My first diagnosis would be acquired valvular heart disease, seeing her long history of dyspnea.
And you think
Second would
there is involvement of one valve or there is involvement of multiple valves from the history? Or that's difficult?
from the history, it comes involvement of one valve, sir.
One valve involvement. Okay. Why do you think it's not a multivalvular involvement from history? This may be difficult sometimes, I admit, but just from why do you think that it's a single wall involvement?
Sir, I have no history of angina and syncope, and palpitations are associated with fatigue.
Palpitations, fatigue can be there in MR, AR. So what we are looking at is the involvement of the aortic valve also. Mitral valve involvement
Yes,
can be multiple features.
mitral valve with it's ruling out aortic valve involvement according to my history, sir.
Aortic valve, it is excluding aortic regurgitation also, or it is excluding significant aortic stenosis.
It is ruling out significant AS, sir, not AR.
Okay.
Palpitations, but if we see that the fatigue and palpitations are predominant, then probably it is ruling out aortic regurgitation also, sir.
And what about any tricuspid valve involvement from this history?
Tricuspid valve involvement, secondarily to mitral involvement could be there, but primary tricuspid valve involvement, probably stenosis is not there because features of abdominal distension and pedal edema are not there. And she could not be so symptomatic if there would be organic TS, because it would prevent volume going towards the LA. She would not be having orthopnea and PND, sir.
Okay. So valvular heart disease, and you think it's a single valve involvement. Do you think it can be a cardiac muscle disease? Peripartum cardiomyopathy, which has not.
Yes, sir. Yes, sir. Probably peripartum cardiomyopathy could be there.
So just to tell you that the rule of thumb is there in multivalvular disease. The rule of thumb is that proximal or upstream lesions will mask the downstream lesion. That is one rule which you have to follow. So if you have symptomatic patients who are largely due to, say, severe mitral stenosis, then the symptoms of aortic regurgitation may be masked. Even symptoms of aortic stenosis may be masked. So from the history, it's very difficult to say that additional lesions are not, unless and until there is definite. Now, palpitations definitely can occur due to aortic regurgitation. They are a presenting feature of aortic regurgitation. But in the presence of mitral stenosis, which is tight, which PND and orthopnea, they may mask the symptoms of
AR.
Okay.
So, Dr. Swati, since you have used NYHA class too many times in both your presenting history as well as your summary of diagnosis, the examiners may be prompted to go in a little bit more details about the functional classifications. And for the benefit of all the students who are attending, one must study about the limitations and the strengths of the NYHA class. So in that scenario, if I want to trick you into a question that this lady is having a palpitation at rest, which are pounding in nature. Of course, they increase on exercise, but they are present on rest. Let's presume it's AR or MR or whatever you may like to call it. And she has dyspnea on exertion, which classifies into NYHA2. And she has palpitations at rest, both of which are part of NYHA. So she is an NYHA2 or NYHA4. She's having palpitation at rest and dyspnea on exertion, NYHA class. So she is an NYHA2 or NYHA4?
NYHA2, sir.
Why do you say that?
So we'll go by dyspnea. I don't know exactly.
So what is the NYHA class? Is it the classification of symptom class or is it something else? What is it testing?
So functional assessment.
Functional assessment, right? So you have to go for the functionality of the patient. Whatever symptom is limited, the functionality will improve. She is having palpitation at rest, but that palpitations are not limiting her activity scale. So activity scale needs to be brought inside. And this is one of the controversial points. Of course, there are 9, 10 controversial points. For the sake of time, the candidate should understand, and in case, I mean, an examiner likes to, go into the controversies. Okay, you can carry on.
Yes, sir. So after the acquired valvular heart disease, my second differential diagnosis would be cardiomyopathy, and probably of dilated cardiomyopathy, sir. Which could be peripartum cardiomyopathy as well, seeing her past history. Other than that, it could be acyanotic congenital heart disease, although the probability of this DD is less because she's not having symptoms in childhood. And last differential would be idiopathic pulmonary artery hypertension.
If you think it is acyanotic congenital heart disease, is it pre-tricuspid or is it post-tricuspid? If you are considering, I mean.
Swati?
Yes, ma'am.
Idiopathic pulmonary artery hypertension. Are you meaning PPH, primary pulmonary hypertension?
Yes, ma'am.
Are you bringing that? Now tell me one symptom which squashes off that. Initially, when Professor Satyavan Sharma asked, you said it is a left-sided heart disease. Primary pulmonary heart disease, will it have left-sided heart disease or PND?
Oh, ma'am.
So why did you bring this differential diagnosis? Till now you are going very methodically and this is unconnected. Don't you think so?
Yes, ma'am. As a diagnosis of exclusion in the last part, I have put it.
So I think this last one should not come, because if you say about the presentation with dyspnea, palpitation, dyspnea, PND, orthopnea, primary pulmonary hypertension won't be there. It is better to omit that.
Shati, that is what I told you at the initial part of your presentation. You told that predominant symptoms are the dyspnea, PND, palpitation. And that is what I asked you, that from the symptoms, it reminds you of a valvular disease. And you told about more predominant stenotic. And I also asked you that stenotic lesions hardly presents with palpitation, orthopnea, dyspnea, usually without any history of pre-syncope or syncope. So from your history, it was well understood that you are dealing with a mixed valvular disease, predominantly a regurgitant lesion because of patient presented with left heart dysfunction, along with the palpitation could be because of the atrial fibrillation or volume overload situation. So that is what I told you initially, that it is hardly to believe it from your history that this could be a case of a stenotic lesion of the aortic valve disease. So now it is go ahead with your further investigation and reports.
Yes, sir.
Context, I would like to just re-stress what Dr. Vijayalakshmi said. For the sake of completion, please do not include any diagnosis which is far away from the, it's enough if you have two differential diagnoses, a cardiomyopathy and a rheumatic heart disease. So for the sake of completion, do not include anything which takes you away from what you have been discussing. That's an important point.
Just a small point, Swati. Which acyanotic congenital heart disease is in your mind, which is presenting with PND?
Sir, in this scenario, I am thinking of post-tricuspid shunt moderate VSD with AR, sir.
VSD with AR presenting with PND. I don't think any one of us will agree to you, that PND going on for so many years in VSD AR.
But the only thing that you can suspect is patient has got atrial septal defect and has developed mitral stenosis. What you call it as a Lutembacher syndrome.
Lutembacher.
Absolutely.
Okay, that is the one you can think, but not VST AR, as Professor Satyavan Sharma said. AR will not cause PND. Okay. The other one is the atrial septal defects. About 4% of them, they have the mitral valve prolapse. So the mitral valve prolapse will have mitral regurgitation, and mitral regurgitation will accentuate the symptoms of AST. So you can have that also. But Lutembacher is the more likely rather than other conditions. Okay.
But Swati, in Luton-Baker, usually orthopnea, PND, usually not a symptom because of what?
Blood gets shunted from LA to RA.
So more of the symptom of CHF rather than PND and orthopnea.
Right side.
Until unless LA and RA press is more than 25, it is very rare in Luton-Baker. So keep in mind. Another condition which congenital you can have, congenital mitral stenosis.
Congenital.
That can explain your symptoms. But symptoms usually start with early childhood.
Yes, sir.
And cord triatrium.
Cord triatrium.
Yeah. What is that congenital mitral stenosis called as?
And parachute mitral valve with single papillary muscle.
Yeah. But what are the associated lesions, likely lesions with that?
Ma'am, it can be a part of
Jones complex.
Jones complex. Yes, ma'am. Supramitral ring, cord triatrium, then LVOT obstruction, supravalvular aortic stenosis, and coarctation of aorta.
Good, good.
Yes, ma'am.
Examination.
Yes, sir. Coming to general examination, patient is conscious, cooperative, well-oriented to time, place, and person, in bed, sitting comfortably. Pulse rate of 100 beats per minute in right radial artery, irregularly irregular, low in volume, and normal in character. No radial and radiofemoral delay. On palpation, condition of vessel was normal, and with all peripheral pulses were palpable and bilaterally equal. Her respiratory rate was 18 per minute, regular, thoraco-abdominal, with no use of accessory muscle of respiration. Temperature, she is afebrile to touch, and temperature was 98.5 degree Fahrenheit. Blood pressure was 108 by 62 millimeter of mercury in sitting position in right arm, with no significant difference in pressure in all limbs. Her JVP was 3 centimeter above the sternal angle at 45 degrees, with single large V wave and prominent Y descent. SpO2 on room air was 98% in all 4 limbs. Height is 160 centimeter, weight 42 kg, BMI 16.3 kilogram per meter square. Here, conjunctiva dental hygiene was normal. No pallor, clubbing, icterus, cyanosis, pedal edema, and lymphadenopathy was there, and no features of infective endocarditis, and no skeletal abnormality.
Dr. Swati, just a comment हमेशा which you people do the wrong thing. If a pulse pressure is 40, then how is a low volumic pulse? You measure the blood pressure 108 and 40, 62. So pulse pressure is okay, so it cannot be low volume. And second, in atrial fibrillation, it is a low volume, it's a variable volume.
Variable volume, sir.
So if you are by this, you are, it seems it's a AF patient.
Yes,
so
sir. Irregularly regular.
Will be variable, and if the pulse, if your blood pressure is showing 40 pulse pressure, then it cannot be a low volume pulse. So this discrepancy should not be there in your examination. That is very important.
Yes. Yes.
And what is the pulse apex deficit?
Yes, ma'am.
Apex pulse deficit.
Apex pulse deficit, sir, it was around 20.
How did you measure?
Ma'am, 2% method I followed. I took help of my colleague, one auscultation and one subpalpation, and simultaneously counting for 1 whole minute, and then we saw it. And I a single person can also do it, but then you have to see only misbeat
I
to
know.
count the
I'm
misbeat.
asking how you did it.
Then I took the help of my colleague along with.
See, now you don't have to do it. You can always do it as a single person. Pulse
Yes, sir.
oximeter
Counting
picks
the
up atrial
misbeat.
fibrillation pulse. So put the pulse oximeter, you'll get the pulse. Auscultate, you'll get the heart sounds. Then you can calculate, isn't it? So
Yes,
that's a single method you can always do it. But make sure the pulse oximeter picks up the pulse wave. Okay.
Swati, just your comment on the blood pressure of the patient. 108/62, and with all what we talked, you think it's a little wide pulse pressure?
40, a pulse pressure of 40 is there, sir.
40.
Yes,
Okay.
sir.
So any comment?
Yeah, it is.
Also in lower limb, it is 70, 122, 70.
Sir,
Any
my
comment? I'm
comment
not
would be
telling
that
that you commit to any diagnosis. I'm just telling.
the peripheral accentuation is there, and pulse pressure is slightly wide, sir, 40, which is correct that pulse volume should be not in the lower range on palpation. And
What should give
Okay,
you
we
a clue.
go ahead.
This should give you a clue that when you are examining, make the patient sit, bend forward, and look for the early diastolic murmur. Because invariably the students will miss that. So this blood pressure, as Dr. Satyavan Sharma is asking, should give you a clue to look for it carefully. Okay. So every step gives you guidance as to what to do next. So this should be a clue to you.
Swati, how did you measure the blood pressure?
sir, I measured it with using mercury sphygmomanometer, sir. Patient was sitting comfortably on the chair, and I measured it in right arm with adequate size cuff, and first auscultatory gap is to be seen with palpatory method followed by auscultatory method.
Which one you took as the systolic blood pressure?
So when we hear that first Korotkov sound, sir, and the pulse appears.
Don't you expect
pulse
there's going to be a problem here? Because the stroke volume is varying from bit to bit.
Yes, sir, because patient is in AF, so I had measured like multiple reading and took a mean of it.
To see the character of the pulse, which artery do you palpate?
Carotid, sir.
To see the disease in an artery, which artery do you palpate?
To see the disease, we palpate radial, sir.
Radial.
For the character, we palpate this thing.
Character is correct. Answer is correct. To see the disease in artery, you have to see the abdominal.
Disease in artery, abdominal. Okay. Sir, radial artery and lima are the two arteries which are never get atherosclerotic.
I know, but to see the disease, you'll have to see the aorta because the case may give rise to a disease aorta. Correct?
Yes.
In modern times, you have triple A's, which are you may miss even with ultrasound if you don't see the abdominal aorta. Okay.
Yes.
Carry on.
Yes, sir. On serious examination, my other system examinations was sir, apparently normal. I'm focusing on serious examination. Coming to inspection, chest is symmetrical. There is no chest wall deformities. Trachea is central. No visible scar mark, dilated veins and sinus. Apical impulse seen in left fifth intercostal space, 1 centimeter lateral to mid-clavicular line. Pulsation seen in the left second and third intercostal space in parasternal area. No visible epigastric pulsation seen, sir. Coming to palpation, findings of inspection are confirmed on palpation. Apical impulse is palpated in left fifth intercostal space, 1 centimeter lateral to midclavicular line, hyperdynamic and diffuse in nature with medial retraction. Diastolic thrill present at apex and parasternal grade 3 heave was also present. Second sound was palpable in left second intercostal space with epigastric pulsations felt with tip of the finger. On percussion, left heart boundaries correspond to apex, right heart boundaries 1.5 centimeter lateral to sternum. Pulmonary area is dull, liver dullness on right side, and stomach tympanic note heard on left side. Coming to auscultation, her S1 was variable.
Before you go to
S2
auscultation, based on up to here, what do you think will be the diagnosis? Generally, you can auscultate. As Madam clearly said, you saw the pulse pressure, you can auscultate for AR. So up to here, what will you look for in auscultation, or what is your provisional diagnosis up to this place? Up to history and inspection palpation.
Yes, sir. From history and inspection and palpation, my apical impulse is out from the midclavicular line. So this suggests that there is LV enlargement, or cardiomegaly is there. And I would think of regurgitant lesion more, yes, sir, or cardiomyopathy. And this P2 is palpable and pulmonary area is dull with the grade 3 RV heave and epigastric pulsations felt on the tip of the finger, suggestive of pulmonary arterial hypertension.
Swati, on the basis of that, you said LV apex is 1 centimeter lateral midclavicular line. So it will rule out any associated stenotic lesion also? You said because of regurgitation. Think that regurgitation may be there, but cannot rule out stenosis.
Yes, sir.
Suppose you are saying that it is mitral regurgitation, but it will not rule out mitral stenosis.
Yes, sir. Yes. It is not for ruling out, including regurgitation into the scenario.
It suggests that there is some regurgitant lesion, but it will not rule out mitral stenosis or mixed MS and MR.
Yes, sir.
Actually, Swati, if I summarize your findings up to this particular point on inspection and palpation and jugular venous pressure, there is an evidence of significant pulmonary hypertension. There is a grade 3 left parasternal heave. There are pulmonary artery pulsations. The JVP is elevated. Patient is in atrial fibrillation. So and there is a diastolic thrill.
Diastolic thrill at apex.
So I think these all are strong evidence for presence of mitral stenosis.
Stenosis, yes, sir.
So there may be additional mitral regurgitation because you think that there is a cardiomegaly and there is a left ventricular enlargement. But all these evidence of significant pulmonary hypertension and a diastolic thrill, they go in favor of mitral stenosis.
Stenosis, yes, sir.
So why you started just suddenly putting it on the back burner?
Sorry, sir.
I think you should have come out like this, that I think with these findings, a likelihood of a mixed lesion is much more. And when there is a pulmonary hypertension, the traditional teaching has been that there is a significant component is of mitral stenosis.
Yes, sir.
Dr. Swati, there is a question for you. Question is, can we have low volume with normal pulse pressure? Can you enumerate the condition which you have you feel a low volume pulse, but the pulse pressure is normal? That is asked by somebody in the chat box. I think it's a relevant question, so I think I should ask. And
so low volume can be hypovolemia state, sir. And low volume with normal pulse pressure.
The pulse pressure is normal, but you are feeling it's a low volume pulse.
It
Usually,
gives you a clue. It's a very important question to give you a clue to the diagnosis. Of course, mixed deletions are always a problem, but
here the volume is varying from beat to beat, so it becomes difficult for you to tell, no? In
Yes,
one
ma'am.
beat it may be more, in one beat it may be low.
so in mitral regurgitation, what is the pulse?
So it is a small, so it is like high volume pulse, but non-collapsing. So small water hemopulse.
It's not a high volume pulse. To feel, it feels little small volume, but its upstroke is rapid.
Rapid,
You can have a
upstroke.
normal pulse pressure, you can have a small volume, and you have significant mitral regurgitation. But of course, mitral stenosis will compound it, but this is the condition where you can have a small volume pulse, but you can have a normal pulse pressure.
What are the conditions where you get the small volume pulse? Because
low volume pulse is seen in aortic stenosis.
That is pulsus tardus.
Yes, sir.
So you have not
Pulsus.
mentioned that. So it is not pulsus tardus. Then? Because whenever you use specific words, you mean something. And that's the reason I'm asking. And that's the reason they have asked that question to you.
Yes, ma'am. Then my pulse is variable in volume most of the time.
Hypertrophic cardiomyopathy pulse is high volume or low volume?
It's a low volume pulse.
Low volume.
You don't call it as low volume or high volume. It is
Only
called
say
as
jerky.
it is spike and dome. So you get the first spike and then you get the dome. Okay, it's a specific one, characteristic.
Pulsus bisperience one.
Swati, you have 15 minutes left. So,
auscultation.
Auscultation. Go to auscultation.
Yes, sir. On auscultation, her S1 was variable and S2 was normal A2 with loud P2 with wide A2 P2 split with normal respiratory variations. No S3 and S4. Rough rumbling mid diastolic murmur extending till the end of diastole. Best heard at the apex in left lateral position with no pre-systolic accentuation. Best heard with bell of stethoscope with breath held in expiration. Mitral opening snap is present, high pitch, best heard at just medial to apex with narrow A to OS gap, which was widening with long cycles of AF and shortening with exhaustion. High pitched, soft blowing hollow systolic murmur of grade 3, best heard at apex in left lateral position, with diaphragm of stethoscope, which is faintly radiating to axilla, increases with expiration. A high pitch pan-systolic murmur, grade 3, best heard at left lower sternal border, which increases in passive leg raising and inspiration. No murmur on back and neck.
Swati, you said there is no pre-systolic accentuation, and
yes,
obviously because of atrial fibrillation.
Atrial fibrillation.
Here, sometimes pre-systolic accentuation despite there being atrial fibrillation. If so, when?
It will suggest very severe MS. Severity of MS. If there is, despite AF, there is pre-systolic accentuation.
When it is, Swati, when it is present in long cycle, in atrial fibrillation, you have short and long side. In long cycle, if you have a mid-diastolic rumble with pre-systolic accentuation, it will show that mitral stenosis is severe.
Severe, yes.
Dr. Swati, you have commented wide A2P2. So
yes,
when
sir.
you are commenting wide, what should be a more word added to wide? Wide variable or wide fix? So when you are telling it's a wide A2P2, then you have to comment upon this.
So it was variable because it was varying with respiration, sir.
Though you have concluded it with a normal respiratory variation, but always say wide variable, because you have make a second heart sound wide. So you should be ready with the explanation in this case.
Yes, sir.
And you have, and then it's loud. How much loud P2 is there? How will you grade pulmonary artery hypertension on the basis of P2 only? But this is a very common question which is asked in the examination.
So if P2 is loud, then A2 at apex.
No. There is mild, moderate, and severe pH. Because a very common question which is asked. When the P2 is equal to A2 at pulmonary area, it is a mild. When P2 is more than A2 in pulmonary area, it's moderate. And if it is heard beyond pulmonary area, it is severe. That is a traditional teaching. So you should always remember these things. But this is a very common question which are asked.
Provided that A2 is normal.
In which condition P2 can be heard at the apex and there is no pH?
P2 heard at apex, like confusing with opening snap, sir.
No, in which condition you can get P2 heard at apex clearly, but there is no pH?
Dr. Balachandran has given no pH.
No
pH. So no pH is your clue. What are the conditions which P2 may be loud without pH? That is the indirect question.
So pulmonary artery dilatation, sir.
So which condition? Some cyanotic congenital heart disease?
You'll get P2 at the apex, but it won't be there won't be pH.
So idiopathic dilatation of pulmonary artery.
ASD is one condition where you will get P2 will be heard at apex, but there will not be a pulmonary artery hypertension. Okay.
What is the reason for this wide A2 P2 split in your particular case?
Despite pH, there is significant pH. Usually there is narrow split of second sound, but despite of that, you had a wide split. Wide
split. Yes, a wide split was there. Sir, because of this associated regurgitation and
which regurgitation?
Mitral regurgitation.
What are the pathophysiology in mitral regurgitation that you have wide split of second sound? Why?
So early A2 and
it is usually in all severity of mitral regurgitation with variable LV function, or it is with normal LV function? Suppose there is mitral regurgitation and there is LV dysfunction. What will happen to the split? Will it still be wide?
No, not be wide. Sir.
Why?
What will be the LV ejection period? If there is a significant regurgitant lesion, then what should be the LV
ejection period? Shortens, sir. It will shortens. LV ejection, because LV will pump blood into LA.
So
if LV is, yes, sir.
In MR, with normal LV function and with LV dysfunction, definitely there will be ejection through both aortic wall and mitral wall. In LV dysfunction, little bit there will be increase in the LV ejection period when there is LV dysfunction is there. So there may be little bit decrease in the split of the second sound. May not be as wide as it is in normal LV function.
Yes, sir.
Swati, you should also be prepared with a question why there is a variable heart sound in MS. You should be prepared. I am not wasting the time, but these are the questions which are usually asked in your Viva. What is the cause of variable S1? Okay?
Yes, sir.
In this case, you have a narrow A2 OS interval. Despite of severe mitral stenosis, what are the conditions in which you don't get the narrow A2OS interval? A2OS interval is increased. What are the conditions? Despite of
The
mitral stenosis,
A2OS, yes, sir.
interval
A2OS
is
interval will increase in hypertension, sir, when systolic BP rises, or
mhm.
with bradycardia, or with associated mitral regurgitation.
And any condition which increase the LVEDP, like
LV,
hypertension, old age, aortic stenosis, it will increase the LVEDP.
yes, sir, and will decrease the A2OS cap.
Okay. How will you differentiate A2OS and this is LVS3?
A2OS and LVS3, first is the location, sir, and OS is LVS3 is a low pitch sound, OS is high pitch sound, and heard with diaphragm, and one is heard with bell of the stethoscope. Then this thing LVS3 apex is if LVS3 is there, apex will be, sir, out, apical impulse will be displaced, and in opening snap with MS, apical impulse is not displaced.
It is the
And
mixed lesion. It is in this patient, you probably MS and MR is there.
yes, sir. And OS will associated with diastolic thrill, sir. And on standing, OS will decrease in intensity.
What about the duration?
Duration on inspiration, it widens, sir.
A2OS and A2S3.
A2OS, sir.
What is the duration of A2OS and what is the duration of A2S3?
Yes,
What is the normal duration?
A2OS, yes, sir. A2S duration is in severe MS, it is less than 0.08. Normal duration and 0.08 to 0.12. Whereas S3 comes this thing later than S3 comes earlier than OS.
I'll tell you one very simple method of answering this A2OS interval other than mitral stenosis. Think of all the LV functions: preload, afterload, LV contractility, aortic hangout interval, then diastolic relaxation of the LV, and elevated end diastolic pressures and cardiac output. So if you remember like this, you will be answering all the conditions which affect the A2OS interval. Okay.
Yes, sir. So the final diagnosis after examination is acquired valvular heart disease, probably of rheumatic origin, with severe mitral stenosis associated with severe mitral regurgitation and severe tricuspid regurgitation, severe pulmonary venous hypertension and pulmonary artery hypertension, NYHA functional class 3 to 4 with atrial fibrillation in congestive heart failure, no evidence of acute rheumatic fever and infective endocarditis.
Swati, everywhere
Yes, ma'am.
you went on using severe 4-5 times. But remember, two things do not occupy the same thing at the same place. You cannot have severe MS, severe MR in the same setting. So that is the fundamental dictum. So you choose which one you want to make it as severe.
Severe MS, ma'am.
You make severe MS, then you will have to explain why the apical impulse is shifted downwards and laterally.
But Swati, severe MS and severe MR is quite possible to have in the same patient. It is standard teaching in the house that severe MS and severe MR is not existing. But in our vast experience, we see that severe MS and severe MR can exist in the same patient. So you may be right. But if you go to the first, that always mention that in severe MS, that mitral stenosis is not severe, or severe MR is there, mitral stenosis is not severe. But our in experience, severe MS and severe MR can exist in the same patient.
There was a question in the chat box, Dr. Swati. When do you get apex outside the left mid-clavicular line in pure MS? Can you get an lateral shift of the apex in pure MS?
Lateral shift with RVH, sir. RV failure is there. If there is RV failure or associated
Usually,
spinal
the answer is when
abnormality.
there is an RV dilatation.
RV
RVH cannot be.
dilatation. RV failure, sir. Yes, RV
failure.
dilatation. Or if there is some spinal abnormality, also you can.
See,
Coming to
what is the hardest point in your clinical examination to say that it is severe mitral regurgitation? What is the hardest point?
displaced apical impulse, sir.
Displaced apex beat.
Yes, sir.
That is not the
How-
hardest.
Hardest
You
is
said that
something
is
else. Yeah.
hardest is
Define
hyperdynamic
the
apex.
apical impulse.
Hyperdynamic apex. That is the hardest. Usually don't occur in the mitral stenosis. If hyperdynamic apex is there, it is usually because of some recurrent lesion. It may be AR or MR.
Yes, sir.
And your white pulse pressure in the blood pressure could be because of the severe MR.
So apical impulse is the hardest point here.
And what is the other point which you can say that it is a mitral regurgitation severe? That is the split of second sound. Despite of severe pH, the split is wide. That again suggests that mitral regurgitation is significant. These are two hardest points in this patient.
And the one thing always you should rule out the severe anemia, because majority of our patient rheumatic heart disease patients are anemic. So the anemia altered the hemodynamics of all the valvular lesion to many extent. So that you should always remember.
Yes, sir.
So Ati, move to the next thing. We don't have any time.
Sir, sir, can I explain the X-ray?
Please, X-ray.
I have X-ray and ECG and everything.
Just
yes,
explain it.
This is X-ray. Yes, sir. X-ray PA view, non-rotated film adequately exposed, taken in inspiration, showing features LV type of apex, no soft tissue and bony abnormalities, CT thoracic ratio of 68% suggestive of cardiomegaly. There are signs of pulmonary venous and arterial hypertension is there. Main pulmonary artery and right descending pulmonary artery are dilated. And upper lobe, bilateral upper lobe vascular markings are prominent. And I can also appreciate a few curly B lines in the basal region as well, sir, suggestive of pulmonary venous hypertension. And this dilated pulmonary artery and decreased markings in the lateral 1/3 of the X-ray, suggestive of pulmonary peripheral pruning, sir. And coming to heart chamber enlargement, there is double lateral shadow on the right side, suggestive of LA enlargement, and straightening of left heart border, slight widening of carinal angle, and LA appendage
Beyond the RA, Swati. In
yes,
fact,
ma'am.
the LA shadow is going beyond the RA shadow.
Beyond the RA. Yes.
That is the point in favor of severe MR. MR
Severe
causes more LA rather than the MS.
Yes, ma'am.
The left heart border is not just straight, it is prominent. LA appendage is prominent. Not
LA
straight.
appendage is bulging. Yes, sir. Yes.
There are two shadow in the left lateral border. What is the two shadow? Which is upper one, which is middle one? There are two prominent shadow.
Yes, sir. One is pulmonary artery, then LA appendage, and then LV. So these are three moguls, sir. Yes, sir.
Okay.
In the ECG, 12 lead ECG normal standardization of limb leads and.
Before going to ECG, what is your comment on X-ray? Your diagnosis?
Seeing this, sir, signs of pulmonary venous and arterial hypertension with prominent LA enlargement.
It support your diagnosis or not?
This is supporting my diagnosis of both severe MS and MR.
And severe PVH and PH?
PH, yes, sir. Yes, sir.
Okay.
Dr. You are 5 minutes more maximum.
Yes, sir. Yes, sir. ECG is a 12 lead ECG with normal standardization.
Just tell me, Swati, what surprises you in the ECG? With all the diagnosis, long diagnosis you gave, anything surprising in the ECG? Atrial fibrillation is as was expected. Anything surprises you?
So prominent LV forces
There was severe pulmonary hypertension.
Oh, axis.
So how is
axis is around 80 degrees, sir. Her axis is around 80 degrees, and I calculated it came out to be 80 degrees, sir. This is one. It is written that if it is above 60, that's suggested of area of less than 1.3, so mitral valve area of less than 1.3.
No, I'm asking severe pulmonary hypertension, no right axis deviation, no right ventricular hypertrophy. How do you explain that?
Yes.
Should be, ne?
Right
parasternal heave and PA pulsations and TR and means PA pressure should be from all your findings around 80, 90. Looks like.
Sir, if the RV systolic pressure is more than 100, then we expect 100% of ECGs showing RVH, but otherwise only 50% shows RVH signs in ECG, sir. So,
what is the side of right atrial enlargement in atrial fibrillation?
Right atrial enlargement in atrial fibrillation, sir.
Yes.
Axis.
Which axis? Same thing, left atrial का भी क्या होता है AF में? And this question is always asked in your examination. So
the coarse fibrillatory wave suggests that LA enlargement is there.
Okay. Right atrial?
For right atrial enlargement, sir, I don't know, sir.
QR pattern in V1. If you have a QR pattern in V1, it suggests a right atrial enlargement. Okay. Some people use R wave criteria also in V2, doubling of the R wave height in V2
yes, sir.
compared to V1.
This is seen in V1 to V2, yes, sir.
Yeah.
This is a blood investigation finding 11 gram of hemoglobin, sir, and normocytic normochromic. So there was no pallor on examination and no anemia seen, sir. Sir, this is the parasternal long axis view showing that there is thickening and irregularity of the mitral valve, some hockey stick appearance of anterior mitral valve and with restricted opening. This is a M-mode view showing a reduced EF slope, which comes in MS. This is showing the color Doppler and parasternal apical four-chamber view showing dilated LA with MR, sir. Around moderate MR, sir.
Why do you want to say moderate, Swati? You see the giant LA and intraatrial septal pushing to that side, and you see the reflux into the pulmonary veins. Once you see the jet going into the pulmonary veins, it is severe. Because whenever there is an eccentric jet, you underestimate MR. So just because the jet is appearing small, don't think it is not severe. It is severe.
Yes. Yes, sir. This is showing that we calculated a mean of 3 to 5 cycles we have taken to calculate the mean gradient. It was more than 10, so severe MS. And pressure half time, according to pressure half time also, it was more than 220 and it was severe MS. Area came out to be 0.8. From 2D assessment of mitral valve planimetry, area came out to be 0.9 at mid-diastole. Regarding tricuspid valve involvement, there was severe TR with respiratory variation, which can be seen, and maximum velocity of 4, which accounts for RV systolic pressure of 64 millimeter mercury.
64 millimeter mercury, and it's not 64. It is 64 plus RA pressure.
64 plus RA pressure, yes, sir.
So what is your RA pressure? Clinically, you have seen the JVP. So what is your RA pressure?
RA pressure was 10, sir, 10.
10 is usually we assume RA pressure. What is the actual RA pressure in your patient? You have a JVP.
Yes, sir. It was from JVP. It was 8.
8 centimeters of water, so you have to divide it by
Yes, sir.
millimeters of
One.
mercury. Okay.
Final conclusion, Dr. Swati. I think we are reaching to the time. It's 12:20. So, what is the final diagnosis? Just
my final diagnosis came out to be after echo examination. It is rheumatic heart disease with severe mitral stenosis. Now I'm changing it to severe mitral regurgitation, severe tricuspid regurgitation, severe pulmonary hypertension, and severe pulmonary venous hypertension with congestive heart failure, and YHA functional class 3 to 4 with atrial fibrillation and no evidence of rheumatic fever and infective endocarditis.
Thank you, Dr. Swati, for a brilliant presentation. And this is my request. Just pen down all the questions asked today immediately after this and send to Dr. Shantanu Guha by mail today itself. It will help us to frame something module for future for DMDNB students. And thank you very much, Dr. Swati. And I think now it is a time that you should listen, Dr. Vijay Lakshmi. And believe
before that, Rakesh, we should profusely thank our examiners, Dr. Satyavan Sharma, Dr. Balachandra, Dr. Goswami, and Dr. Rishi Shetty for asking such brilliant questions. Which actually I was feeling I am sitting in my seminar room and discussing the questions and answers with the students. Exactly that gave this interrogation gave that sort of a feeling. Thank you, sir. Thank you very much, all of you. And now let us.
I have got one point to just clarify. One answer was not given.
Continue your slides,
volume and normal pulse, low volume and normal pulse. So I think this is a very interesting question in the sense that whenever someone discusses any clinical case or just thinks about any clinical case, one should think about the hemodynamics in terms of the various hormonal and endocrine system. So whenever there is any peripheral vascular resistance increase, that time you might get actually the normal pulse pressure, even if there is no, even if there is a low pulse volume. So that is one very tricky point. And another point is that while discussing the clinical points, one must consider not only the acquired heart disease, congenital heart disease together, as Dr. Satyavan Sharma was pointing out, regarding normal, loud P2 with the normal PA pressure. So there, one will have to think about or rule out about CTGA, where the pulmonary artery is in front of the aorta. That time you can get the loud P2 even at the apex or at the parasternal level. So some of the considerations should be made while thinking about a clinical case, not only pure rheumatic heart disease or pure cardiomyopathy or like that. Even SLE will have to be considered in this particular patient because a lot of similarities are there, and of course you are to rule out. So with these few words, I'm very thankful to Dr. Shantanu Guha and his team for beautifully actually presenting and also moderating the session.
Thank you, Mrinal. Thank you very much, Dr. Das. Let us move to the next part of our program, a talk by Dr. I.B. Vijay Lakshmi on newer advances in the management of rheumatic fever and rheumatic heart disease. Let us straight away start this session. Dr. Vijay Lakshmi, please.
Thank you very much, sir. That was a wonderful bedside clinics. And it took me to the memory lane 46 years back when I presented as a young first-year MD student to Dr. Padmavati, the multivalvular disease. And it was such a super hit. And that day I decided to become a cardiologist, and hence I dedicate my today's lecture to Madam Padmavati. It is said, you aim at the sky, you hit the tree. I aimed at becoming like Padmavati, but ended up just remaining what Vijay Lakshmi is. So it is estimated that globally more than 40 million people are affected by rheumatic heart disease. More than 4 lakh people die annually. And WHO bulletin in 2018 said that, and nearly 60% of deaths are premature. They do not survive till the end. India has the highest prevalence of globally, and it contributes to 25 to 50% of the newly diagnosed cases, hospitalization and deaths. And hence, it is extremely important that today the CSI has taken the responsibility of starting like the opening batsman with the rheumatic heart disease, which the corporate hospitals forget. And as Dr. Padmavati said, unfortunately, India is in the phase of epidemiological transition. On one hand, there is substantial burden of RHD, and on the other hand, resources are scarce, and hence prevention is very important. And hence, it is very important to know the newer advances to make the take the teeth out of the disease, which is known as licking the joint and biting the heart. And here in 1998, when I went to Minnesota for the training, Ed Kaplan had just written for the World Health Organization that in the editorial, detection of active rheumatic carditis is a great prognostic and therapeutic importance and is currently based on zones criteria. The fact that penicillin has failed to eradicate this disease process is irrefutable proof that we need more laboratory and epidemiological clinical research. And in 1998, I presented my data to him and showed him that echo can be more precise and it can prevent both overdiagnosis and underdiagnosis. And I showed him how polyarthralgia was important. 70% of them had polyarthralgia and they had echo evidence of carditis. And clinically diagnosed cases, nearly 40% of them did not have rheumatic heart disease and it was not carditis. And at that time he said, Vijay, everyone is not as good as you in the echo. But then I said, Ed, would you like to err on the right side, on the wrong side? And then I said, erring on the right side. He said, what is that? I said, erring on the right side is making overdiagnosis and giving the penicillin prophylaxis, which is not even $250, and erring on the wrong side is missing the diagnosis and patient goes for valve replacement or the valvuloplasty. And hence, friends, then he said, you are disarming me. And at is the time when I showed the valvulitis, valve prolapse, annulitis, ventricular annular enlargement, caudal rupture, all can be made out by the echo, which cannot be distinguished by the clinical examination. And he wrote, blessings must be earned. And because of his encouragement, I went ahead and did the second prospective study. And in that, we noticed that MR was diagnosed in 144 patients, whereas echo diagnosed in 239. AR was missed in nearly two-thirds of the patients, and the TR was much more missed. And today, I must congratulate that Swati was able to detect the TR and the MR very well. And hence, I told echo is the key, and this was published in the Cardiology in Young in 2005. And then how the severe MR can be made out, and both the overdiagnosis and underdiagnosis can be prevented. And then I gave the Vijaya's echo criteria, where all the important features like mitral valve, aortic valve, tricuspid valve thickness more than 4 millimeter, mitral regurgitation, aortic regurgitation more than 2 points, then mitral valve prolapse, then rheumatic nodules, carditis, pericarditis, caudal tear, reduced mobility of the valves, and the hyperechogenicity of the submitral structures. All of them, if you have more than 6 points, that is more than 3 features are there, we make it as rheumatic. And at that time, Patricia Ferreri, chairman of Zones Criteria, was in the audience, and they were not ready to accept. But believe me, in 2015, whatever we said, the West agreed for that. And today, the subclinical carditis has been made as a major criteria for the first time. And this is how in the past we were taught. The 50% of the rheumatic fever do not have rheumatic heart disease, do not have the past history. was because the subclinical carditis was missed in nearly 50% of the cases, and hence now they have added that as a major criteria so that no patient goes without the penicillin prophylaxis. Then polyarthritis was always a major criteria, but now even monoarthritis has been included as a major criteria, especially in the high prevalence state. And polyarthralgia initially in 1944 was major criteria, and then it was made as minor, but now again it has been made as a major criteria, especially in the places where it is the high prevalence is there. The other three remain the same, and what is the most important recent inclusion is including echocardiography as a major criteria. And that is the great thing that it has happened. And today we must feel happy that whatever the Indian population study we gave, and that has been accepted. And here you can see that Ed Kaplan is still there, and two major studies, the largest series in the world, have been included in this study, and both are my data from 452 patients, 333 patients, and today they have made echo as a major criteria, included the subclinical carditis also. So here if you look at the whole difference between the past and the present newer trend is monoarthritis and polyarthritis are all in major criteria, including polyarthralgia. That means wherever less than 1 per 1,000 cases are present, that is the low risk group, there the old thing remains, only the subclinical carditis is included. And in the moderate to high risk population, where more than 2 per 1,000 patients, people are there, their monoarthritis, polyarthritis, and polyarthralgia are also included as the major criteria. And polyarthralgia remains in a minor criteria in the low risk group. Monoarthralgia also remains a minor group even in the moderately high population. And ESR difference is 60 and 30, and otherwise the rest of it same. Now today, what do we do if the diagnosis is uncertain? The present day data is not to leave any patients out of penicillin prophylaxis. Here, where the diagnosis is genuinely uncertain, it is reasonable to consider to offer 12 months of secondary prophylaxis, because once the carditis is there, they can have lifelong disability and they can improve also. And hence, they are bringing more patients into the net of secondary prophylaxis by giving for 1 year secondary prophylaxis, even in the patients where the diagnosis is not very certain. Now, here you can see that in a dilated cardiomyopathy, here there is a non-compaction also. The central jet is there. Though it is a pathological jet, this is not a rheumatic, because the valves are thin, and then ejection fraction is only 36. And you must remember, Dr. Tandon has shown with the muscle biopsy that there is no myocarditis in rheumatic fever, and as a result, the ejection fraction is invariably not reduced in cases of rheumatic, and this is a dilated cardiomyopathy with non-compaction. So this is the physiological with the pathological, and this is very important to distinguish between the physiological MR and the pathological MR. Unless there is a severe, the valve regurgitation is associated with the thickened valves or beaded appearance or hyperechogenic submitral structure, unless the echo score is more than 6, we do not make it as a rheumatic. Now, there was a time in the past they used to do the autopsy and show like actus ulcer like structures at the tip of the mitral valve. And these are the small thrombi form the valve at the edge, giving rise to the ridge or row of pink nodules. And this is seen what we were seeing in the past. The present we see them as the beaded appearance. And I want all the students to memorize this picture of beaded appearance. You see the small beads around, and then there is the tip of the AML is prolapsing. And this is the classical feature of rheumatic carditis. And if it is there, we must suspect the rheumatic carditis. So this is a 15 years old child, not only the thickened, reduced mobility of the PML, beaded appearance of the AML, PML, you can see that the beaded appearance is seen on the submitral structure like the papillary muscle and the caudate too. So that indicates that the extensive inflammation in the submitral structure. So you may have the thickening, hyperechogenicity, beaded appearance, shortening of the caudate tendineae or elongation of the caudate tendineae. All those features are there. So gone are the days when in the histopathology, the pathologists used to show the nodules, how they are. And then when we were students 50 years back, we were taught how to palpate the nodules on the extensors. But today we can look at the nodules in the same way as we see in the histopathology or clinically. So these are the seen just proximal to the free edge of the mitral valve, where the cusp comes in opposition to the site of the maximum natural trauma. So when they are rubbing with each other, the inflammation is more, and over that there is a fibrous cap, and that forms the nodule. And this was published also. Here you can see that the transthoracic echo shows the club-like 9 millimeter AML, 6 millimeter PML, and apart from the nodularity, you can see that the club-like nodules. And this is the classical picture of the rheumatic carditis. And hence, today the world has accepted, and the AHA in their new zones criteria has given the pathological mitral regurgitation, the FRO criteria, as we had taken in the past and presented in our data, more than 2 views, more than 2 centimeter, and the peak velocity of more than 3 per square. And then the systolic jet should have at least 1 envelope. And the pathological aortic regurgitation also has got the same features, and pan-diastolic jet has to have the envelope. And apart from that, the other findings of valvulitis are the thickening of the valves and the jet. And here you can see that the thickening has to be important, and pathological aortic regurgitation also must be seen. The annular dilatation, caudal elongation, caudal rupture, regurgitation, all these things are taken as the features of acute mitral carditis. And then you can have the leaflet thickening, caudal thickening, fusion, restricted mobility of the AML, PML. Most often it is the PML, and over the period there can be calcification, irregular or the focal thickening, what we call as a beaded appearance, or the nodularity and coaptation defect and restricted leaflet mobility. All these things are taken as a feature, and all over the world these are accepted, and a student should know all these features so that they don't miss the diagnosis when they are doing the echo to confirm their diagnosis. So this is a 14 years old patient who had multiple flitting type of migratory joint pain, a classical one, and had a cough, and the ESR was only 20, but ASLO was 421. And here you can see that the PR interval is prolonged. The first degree AV block is a classical feature of rheumatic fever or the carditis. Penicillin was advised, and the patient did not take because he was not very severely symptomatic. See, unless they are scared of something, they do not take. So here you can see that in the apical 3-chamber view, it illustrates the thickening of the AML, PML, hyperechogenic submitral structures, and you can see that the tip of the AML is prolapsing with a severe MR and a mild AR. So here the diagnosis is not a problem. But the diagnosis is a problem where the echo features are not fitting into the Vijaya's echo criteria. Here you can see that there is a redundant myxomatous mitral valve with the collapse with the MR, and the echo score is only 4. So once the echo score is 4, it is not a rheumatic one, and then when we investigated, it was a mucopolysaccharidosis with the myxomatous valve with the grade 3 prolapse, and that was not a rheumatic. And here you advise only the SBA prophylaxis and not the rheumatic prophylaxis. Whereas in contrast, you can see that there is an eccentric MR, and then there is a thickened valves. The pericardial effusion is there, and that is the pericardial effusion. Invariably, it is mild, and the caudal tear is there, and the echo score is 10. So once the echo score is 10, it is definitely rheumatic carditis. In a known case of rheumatic heart disease, if the patient comes with a fever, many people would like to think in terms of recrudescence of rheumatic activity. But you must correlate your clinical findings. If there is anemia, microscopic hematuria, and splenomegaly, look for the echo carefully. And if you look in the parasternal long axis, you can see that there is a mobile vegetation on the LA side. And that is a classical feature of bacterial endocarditis. And if you look at the tip of the AML very carefully, there is a perforation. So remember, the patient had rheumatic heart disease, and on top of that developed bacterial endocarditis, and the present symptoms have become worse because of the severe MR. So though the beaded appearance is there, though there is MR, this is not carditis. On top of the rheumatic heart disease, there is a perforation and the bacterial endocarditis, making the symptoms worse. So remember, if the symptoms become worse, either it is due to the atrial fibrillation or due to the bacterial endocarditis or superadded infection. So echo is so specific. The precise and the early diagnosis can be not only made, we can also rule out the other conditions. Like you can see here that the PML is flail. Invariably in rheumatic heart disease, the PML movement is restricted, and here it is flail. And if you look at the heart failure, the symptoms the child had come, there is a non-compaction of the LV. So the heart failure is not only because of the flail PML and the severe MR, it is also because of the non-compaction. So here you can see that invariably the AML prolapse is seen in the rheumatic, but in this patient, you can see in the short axis, the PML prolapse is there. So the PML prolapse, non-compaction, severe MR, this doesn't fit into the rheumatic, so it is not a rheumatic, it is a non-rheumatic severe mitral regurgitation with the flail mitral. So this child was diagnosed in a medical college where I did my MBBS, and then they referred the case to me for the further management. The child was on penicillin prophylaxis, and they gave the pulmonary artery pressure as 90. So since it had come from my college, and then I did not correlate the 11 years old with the girl with the 90 millimeters of pulmonary artery hypertension, I went myself to do the echo. And when I looked at it, watch carefully, the mitral valve is not thickened. There is a prolapse. There is eccentric mitral regurgitation. And what is very important that no echocardiographer or a cardiologist should not miss is the hyperechogenic glistening endocardium. In case of rheumatic, you never get a hyperechogenic glistening endocardium. Glistening endocardium means there is ischemia. Ischemia invariably in children occurs in the alcapa. And alcapa is one thing which can cause the dysfunction of the papillary muscle, relapse, MR, but this is not a rheumatic. So when we went to the short axis, you can see that in the short axis, there is the alcapa there. So the left pulmonary, left coronary artery is arising from the pulmonary artery. It was confirmed by the angio with the selective angio as well as the aortic root angio. You can see that in the liver phase, the pulmonary left coronary artery is arising. So that means the echo is so precise. The diagnosis, whether rheumatic, non-rheumatic, what is the cause for the MR, everything can be made out by the echo. The echo today is so advanced that the color Doppler and the Doppler can show you. You can see that the papillary muscle is there, the AML papillary muscle, from there the chordae coming and attaching to the AML are torn. So literally you can trace the chordae with the present day echocardiography, and you can see that the rolled up chordae are seen at the tip of the AML. So this is not a vegetation. vegetations will be on the LA side and the torn chordae will be on the LV side. So that's how you can make out that this is the torn chordae. So this was from the medical college where I did my MD and the DM, that is the Bangalore Medical College. And the patient was put on the steroids because he was not improving. And then they referred to me. When I did the echo, I saw that both the AML and the PML chordae were torn. So the flail AML, flail PML causing the severe MR. So such a patient, even if you immerse in the drum of steroid, is not going to improve. So this is the child, once the recovery of the acute carditis occurs, the child has to go for the valve repair. And today valve repair has become so good that in fact we can avoid the valve replacement. And this is the patient with a severe AR and the MR at the age of 16. If the child has to go the double valve repair, you can see what is the enormous thing. So this is in the TCT in Washington, DC. I presented my data on juvenile mitral stenosis. Remember, juvenile mitral stenosis is not like an adult. In fact, it is called as the malignant mitral stenosis because of the severe submitral structure fusion and the severe pulmonary hypertension. And here you must remember, prevention is better than cure is very important. And for this data, the Japanese doctor who came, they came and presented me a beautiful box to me for my work for the juvenile mitral stenosis. And when we did the data compared with the adult, that was done in Jaideva, and you can see that the pulmonary hypertension reduction is much less compared to the adult. The valve orifice attained is also much smaller because of the severe mitral stenosis. And this is one of the patients. You can see here that 12 years old child, RA-RV are dilated with RV dysfunction. The LV is the smallest, and you can see that literally papillary muscles and the chordae have fused to become almost looking like a single papillary muscle, and that is the severity of the submitral structure. And doing the balloon valvoplasty here is difficult, and Dr. Satyavan Sharma is the pioneer in the balloon dilatation, that is the PTMC, and he used to use the double balloon. And now what we are doing is we dilate this submitral structure initially with the peripheral balloon or the single balloon, and then go ahead to dilate it. Otherwise, we land up with the severe mitral regurgitation if we use straight away the Inoue or the Acura balloon. So this is the patient. You can see that the orifice is less than 2 square centimeter. Less than 2 square centimeter is so very small that even the stretched profile of the balloon that we use is 3.6 millimeter. And so you have the puncture needles, the structure, the balloon, everything for the pediatric, or that is for the juvenile mitral stenosis has to be separate. And here then we got the good result in this patient, despite of it being very severe. And you can see that how severe was there. E by A ratio, you can see that A is so severe, and 35 by 15 millimeter gradient, it came down to 13 by 7. So one has to be extremely careful when you are doing the balloon valvoplasty for the juvenile mitral stenosis, because the LA is not roomy like in the adult, and then you may puncture the roof and then cause the tamponade, and hence you have to go very carefully when you are puncturing. And this is a 2 years, 3 months old child with already the mitral stenosis, tricuspid stenosis, and then the orifice was 0.4 square centimeter. So today's the hardware and the technology have advanced so much that any size, any shape, any orifice, we are able to tackle with that. So this is the 16 years old patient presented with the easy fatigability on walk thing, and also choking sensation, chest pain, and nobody bothered. And then the patient had the irregular pulse, presented with the pulmonary edema. And when we punctured, it was a case of dextrocardia. So dextrocarditis inversus, and the patient had MS as well as the AS. So always you remember the dictum is to open up the distal obstruction and then come to the proximal. So we, in order to open the aortic valve and to keep the pacemaker lead, I punctured both the sides and my guide wire would not go into the vein. So I was surprised whether there is obstruction. Then we did the CT and then again we saw that this was a May-Turner syndrome. So May-Turner syndrome is because of the right common iliac artery is obstructing the left iliac vein, and as a result our wire cannot pass through that. Then you have to go with the dilator to open. So from the jugular approach, we did the pulmonary angio to see how big is the LA, and then punctured it from the left pulmonary vein, keeping the, instead of 4 o'clock position that we use for puncturing, here we have to keep the needle, puncture needle to the 7 or 8 o'clock position, then punctured, and in the same sitting did the aortic balloon dilatation and also the mitral valve. And here, instead of putting the U guide wire, we put the same jalebi guide wire into the LV and then pushed it because it was a very severe pulmonary stenosis. So whether it is a dextrocardia, dextroversion, or associated lesion, all can be tackled with the current hardware and the technology that we have. And so here the gradient came down from 63 to 6/3. So I presented this paper in the nightmare case in Miami PICS, and then they were wondering how can any mitral valve gradient could be 63. And here you can see that we had a very successful, good result. And just now you saw that Swati presented the case. During the pregnancy, the patient became symptomatic. So this lady was asymptomatic until she developed hemoptysis, what we call as a pulmonary apoplexy. Half a liter blood she was coughing out, and when we did the echo, it was a 0.4 square centimeter, a pinpoint mitral stenosis. So we did the emergency balloon dilatation, and in the same evening she delivered, and this is the next day morning, she's sweating. Gone are the days in the past such women used to die on the table, or the child born to these patients with the rheumatic heart disease used to die, like the case which was presented. But today, with the advancement in the technology, both the child and the mother can be saved, provided between the 3rd and the 4th trimester, we can cover the abdomen and do the balloon dilatation on the echo itself. And with the minimal fluoroscopic time, with the echo guidance itself, we can puncture and do the dilatation. Out of 17,000 PTMC 10 years back, 605 were the pregnant ladies, and majority of them came with the NYHA class 3 and 4, and they were in emergency, and the procedure success was almost 95.5%. Literally, this is a life-saving procedure. But today, not only the transthoracic echo, thanks to the transesophageal echo, here you can see that in the transthoracic, there is a doubtful thing, but we are not able to make out clearly what it is. And no PTMC in adult should be done without the transesophageal echocardiography to rule out the left atrial appendage clot. So here you can see that it's something like a flower. It is coming and jutting and going back, and that is because the organized thrombus from the left atrial appendage is protruding into the body of the LA, and apart from that there is a SEC. So the SEC and the partially organized and partially mobile thrombus, this is a high risk for doing any balloon dilatation, and hence this patient has to be put on heparin and sent for the open valvotomy, that is the OMV. And today we have a 3D, 4D echo to help us, and not only the pediatric cardiologist or the cardiologist, even the surgeons they are benefited by this. And here the post-surgical paravalvular leak also can be closed with the guidance of the 3D and the 4D echo. And so today, no patient should develop valvular heart disease going for the double valve, triple valve. They should be prevented in advance, or even if they go, they have to be detected in time. And whether it is a balloon dilatation or the surgical, then we have to balance between the two. And today, the repair is far overweighs the replacement. In the repair case, there is no need for the anticoagulation. And here, the European Society guidelines has given that the mitral valve repair should be the preferred technique, and whenever it is possible. Surgery is indicated in symptomatic patients where the ejection fraction is more than 30. But today, we have changed the stitch in time saves 9 to stitch in time saves life. And even before the patient becomes symptomatic, develops fibrillation, or goes into the heart failure like this patient, and that has to be tackled. And today, whatever we have, the thing is, once the ejection fraction is more than 55, even if the patient is not into the florid fibrillation or florid heart failure, the patient should go for repair. And today, repair indicates not only the valve repair, they can have the shortening or the lengthening of the papillary muscle, and all this can be done with the excellent result. And in our own hospital in Jaideva, the giant left atria, this requires just valve replacement will not help. They have to do the plication to reduce the size of the LA. They have to do the maze procedure to prevent the atrial fibrillation and the thromboembolism. You can see here that the left atrium has gone beyond the right atrium. This is the giant LA. After plication and the you can see the size has become almost normal. Dr. Prasanna Simha, who was trained by Dr. Sampath Kumar, he has achieved almost 95% success rate, and out of 1,680 cases who underwent repair, and here they have done the repair, it was published, and here you can see that they can do the caudal shortening, the releasing of the chordae, and also with the artificial grotex, the annuloplasty can be done and the repair can be done. And if there is a tricuspid valve involvement, even the tricuspid valve has to be repaired in the same sitting. Otherwise, even despite the valve replacement, the patient will go into failure if the tricuspid valve is not repaired in time. So here, the excellent result, and this was published in my monogram, and you can see that the people have to change their mindset. Not every LV dilatation is due to the dilated cardiomyopathy. And here, what was diagnosed as dilated cardiomyopathy elsewhere, we saw that there was a severe AR. So remember, in dilated cardiomyopathy, you never get the collapsing pulse. And even today, the clinical diagnosis or the clinical features are the solid foundation. And if you miss the clinical findings, you miss the other findings also. So here, this patient required the aortic valve replacement, which was very, very rare, because aortic valve involvement is less than 25% of the cases. So this is the post-BMV patient came with the gangrene of the fingers. And when we did the echo, there was a mobile vegetation attached to the AML, and some of them had embolized, causing the gangrene. So remember, these patients, despite doing the balloon valvoplasty, they have to be both on penicillin prophylaxis as well as the SB prophylaxis. If the SB prophylaxis is not given, they end up with the bacterial endocarditis and the thromboembolic phenomena. Hence, The most accurate role of the echo is accepted all over the world, and everyone. In fact, when I spoke in the Pediatric Cardiology World Congress in South Africa, they gave me 6 lectures only on the rheumatic heart disease and called me as the queen of rheumatic heart disease. That is because the school-based and other features, they have started accepting whatever the criteria we have given. And prevention is better than cure. The echo screening in the schools, echo plays important role in with the first diagnosis itself, in the subclinical carditis, and then in the recrudescence, we can find out whether it is a bacterial endocarditis or recrudescence, and whether it is pregnancy or stroke or anything. We can literally save the patients if we become experts in the echocardiography. If you look at the future, we are going to get the vaccine. It is still on the way, and nasal spray, intranasal spray are going to come. And until then, echo is the key, and it is like a fire extinction. What we think like an impossible burden of rheumatic heart disease can be made as possible by each and every cardiologist being expert in echo criteria and echo diagnosis of the carditis, and thereby bringing more children into the prophylaxis of the secondary prophylaxis. So, friends, to conclude, patients with clinical and subclinical carditis are more likely to be detected during the first attack, and if they have got a involvement of the heart in the first attack, they are likely to be devastating changes again when they have the second or third attack. So the new zones criteria, echo has been made as a major criteria, subclinical carditis has been made as a major criteria, so that what we were taught by our teachers, 50% of the patients do not have the past history. It should become like a past history of the rheumatic fever, and the 3D, 4D, transesophageal echocardiography, all of them have given extra edge to the cardiologist to make a precise diagnosis and make the the treatment in time, so that the mortality, morbidity, all can be reduced. Hence, the knowledge of contemporary issues and the recent advances, what can be done should be learned by everyone, so that it is important in saving millions of children who are suffering. And this is one of my patients who came on the deathbed. So friends, in our country, we have malnutrition, low weight, poor hygiene, poverty, illiteracy, ill advice, and reaching late to the hospital, lack of prophylaxis, everything is there. But still, protecting and preserving the heart of the children is not a charity, it is the bounden duty and the social responsibility of all of us. Today is not just the Valentine's Day, today is the World Congenital Heart Day too. And hence, I wish each one of you to be expert not only in the congenital and also the rheumatic heart disease, so that you can reduce the burden of morbidity and mortality. So I would like to end my lecture with what John F. Kennedy said in UNICEF in 1964. He said, children may be victims of fate, but let them not be victims of our neglect. They may be born to the poor family and suffering with the rheumatic valvular heart disease, but bringing them into the net of secondary prophylaxis and then the SBA prophylaxis, the children can lead a near normal life with the proper treatment in time. Thank you very much for a kind and patient hearing. And I thank Dr. Shantanu Guha and the CSI for giving me an opportunity to present my data. Thank you very much.
Thank you, ma'am. Thank you for a very elaborative talk on rheumatic heart disease. And there is few couple of questions which is in the chat box.
Okay.
The first question is why arthritis is migratory in rheumatic heart disease? That is a question always asked in examination.
Always asked, and always we say that we don't know. So that shows that we have not understood the nature. And my teacher used to tell, chorea and arthritis do not occur at the same time. Thank God. Otherwise, a painful joint having choric movement, how horrible it would be. So these are the things we do not know. Korea, it takes 3 months, so the arthritis is not there. Why it is migratory, it is not known.
And the second question is post BMV, how to assess the mitral valve area? Is it a PST or a gradient or a 2D, which is important?
No, it is a very, very important question. It is not just the orifice. The submitral fusion will be there. So the gradient is there also. So we have to assess the submitral fusion. We have to assess the orifice and also the gradient. And apart from that, the pulmonary hypertension. So at 3 levels, there is a obstruction. So all have to be assessed. The child has to be assessed as a complete rather than concentrating only on the orifice area.
Rakesh, is there any other question?
No, sir. In chat box, there is no other question. So,
Rakesh, how many participants are there?
sir, this is only faculty. I think the participant we will.
It was more than 400 when I got the last information. Say about half an hour back, before Dr. Vijayalakshmi started her lecture, it was around 400. Now I don't know what is that. That I will give the feedback.
Shantanu, now it is the final number is 412 and all are PG students as of now, without the faculty.
So by including the faculty, it will be around 450.
Correct.
Right. Thank you very much for this update. And thanks, Dr. Vijayalakshmi, for this excellent oration. And what Rakesh asked you first, that was my question, because I didn't know why the arthritis is migrated. I thought, let me ask you. So if you can answer it.
So my first monogram that I wrote has come for the second edition. So while updating, I again looked back. There is no explanation for why it is migratory.
I didn't get anything. That's why, that is the reason why I asked you. Anyway, thank you very much, everybody, all the examiners, Dr. Vijayalakshmi, the presenters, all the past presidents who were present, president and the past presidents who inaugurated the program. Our next program is going to happen on 28th of February. This will be on a congenital heart disease. There will be a case of congenital cyanotic heart disease, and there will be a talk on the approach to a patient with cyanosis. So this will be our program for the next day. The timing may be a little different. That will be intimated on time because of a CSI executive committee meeting. The timing may be deferred by a couple of hours or so. The exact timing we shall intimate in course of time. And I thank all the delegates, all the students who participated in this meeting. I hope you got some positive things which will help you in crossing through your exams and also will impart some knowledge so that you become a better cardiologist in time to come.
And save more lives. Thank you, sir.
Thank you very much. Thank you very much. Kunal, you wanted to say something?
So we want to thank you also starting such a wonderful thing for the postgraduates. Why this is important is some of the centers are very good in teaching, some are not. To get the uniformity and make the learning available for every postgraduate in every center, I think the CSI has taken not a small step, a giant leap for making the whole teaching available for each and every student in India.
Thank you. See the galaxy of the examiners. Dr. Goswami was my co-examiner many times. Dr. Balachandar was my co-examiner. I took exams with Dr. Satyavan Sharma. I know their mindset. They are fantastic examiners. All of them are fantastic examiners. And I thought to make them sit on the same dais with Rishi Shah. Rishi was also my co-examiner and I know his mindset. So I thought let them sit in the same platform and ask questions on rheumatic heart disease. That will be splendid. And in fact, today's this first case was a wonderful exhibition of rather the types of questions what our examiners asked. Exactly this type of questions, you know it very well. This type of questions are being asked in all the examinations, all the DM and DNB examinations. So I want that the students get familiar with their examiners and with their questions, so that will help them during the exams. And thank you very much.
Did very well. Dr. Swati did very well, except for one or two.
Yeah, but this is expected. This is expected. Thank you very much. And let me thank everybody who has helped us in organizing this program, and see you. Looking forward to meet you on 28th for our second program. Thank you very much.
Thank you. Thanks all.